Okay, so many thanks for the kind introduction and also for the invitation. I'm very sorry that I could not attend, but now as a father of 3 kids and a very short time frame and the new job in Berlin, I was not able to come to Lille, but of course I'm happy to join at another occasion. Yeah, and I would like to present you some of our work, which mostly, I have to say, has been performed in Erlangen in southern Germany.
You have to share your screen.
I think
yeah, it's okay. No, it's everything.
Yeah. Okay, can you see it? Yeah. Do you see the screen?
Yes. It's perfect.
Okay, good. Yeah, and so this work has mainly been performed in Erlangen.
Gerhard Krönke in Berlin.
Pardon me?
Merci de couper vos micros à distance, tout le monde.
Yeah, so there's some noise.
So we start again.
We start again. Okay, so many thanks for an invitation and for the introduction. I would like to present you some of the data that has been mainly performed in Erlangen before I moved to Berlin last year. So most of you are familiar, most likely, with systemic immunity, systemic autoimmunity, and one particularly severe autoimmune disease is systemic lupus erythematosus. So it's characterized by a break of self-tolerance to ubiquitous antigens, such as DNA and other nuclear antigens. And usually it's considered as an autoantibody and immune complex-driven inflammatory disease that basically can affect every organ in the body, most commonly the kidneys, skin, joints, but also the central nervous system. And this severe affection of different organs is potentially life-threatening, and many patients have a severe disease course. And what's also very important to state is that despite novel treatments, it's still considered as a chronic disease. So patients usually require lifelong treatment with different immunosuppressive drugs, including steroids or cyclophosphamide and mycophenolate, for instance. B cells are thought to play a major role in systemic lupus. Here we know that B cells can give rise to short-lived plasma cells that most likely contribute to highly pathogenic autoantibodies such as anti-DNA antibodies, which most likely drive this autoimmune disease, as well as long-lived plasma cells that reside in the bone marrow with a long half-life, which also contribute to autoantibody production, but the spectrum of autoantibodies they produce is slightly different. So they produce other anti-nuclear antibodies, such as Rho and La antibodies. These immune complexes that are formed by this B-cell-driven autoimmunity then drive inflammation in the tissue, in kidneys, for instance, and here type 1 interferons play an important role. And the type 1 interferon receptor has also been recently utilized as a therapeutic target for antibodies such as anifrolumab that block interferon signaling. We know that B cells are a potential target for this autoimmune disease or for the treatment of this autoimmune disease. And here, different stages of B cell development show different surface expression of distinct molecules. CD20 is one of these molecules that has been used as a target to deplete B cells with antibodies such as rituximab. But there are also other surface antigens, such as CD19, for instance, that can be targeted both by antibodies but also by cellular therapies. And I will talk about that in a minute in more detail. One observation in the treatment of lupus patient was that, interestingly, an anti-CD20 antibody, here in this case rituximab, was very efficient in depleting B cells in the peripheral blood. However, despite this very efficient depletion of B cells, clinical data showed that overall the clinical benefit was very modest, And in this trial, for instance, there was no superior clinical efficacy in comparison to placebo. So in this case, the patients obviously also received other treatments, but data like this was kind of puzzling, as despite a strong B-cell depletion and despite the important role of B-cells in this disease, the lack of additional clinical benefit was kind of surprising. One likely explanation for this discrepancy is that despite the fact that rituximab depletes B-cells very well in the peripheral blood, there's hardly any B-cell depletion in lymphatic organs. What you see here, for instance, is the number of B-cells in lymph nodes after rituximab. And here you see that in the lymph nodes, despite rituximab treatment, there are still quite a large proportion of B-cells present, which potentially can then also contribute to plasma cell formation and autoantibody production. So overall, rituximab is insufficient in depleting tissue B-cells, as well as in having a superior clinical efficacy. One other approach to deplete B-cells, so-called CAR-T cells. CAR stands for chimeric antigen receptor. And in this case, the CAR consists of an antigen binding domain of an antibody fused to a membrane domain and intramembrane domain of a T-cell receptor. And this combination gives a high efficacy when this CAR is transduced into T cells, allowing them to recognize surface antigens and very efficiently lyse cells that express the surface antigens. And so far, CAR-T cells have mainly been used for the treatment of hematological diseases such as B-cell lymphoma or B-cell leukemia. However, there are also data showing that anti-CD19 CAR-T cells, so CAR-T cells that deplete B-cells, are also a potential tool to treat autoimmune disease. So here's data from a preclinical mouse model, so two lupus mouse models, the NZBW and MRL-LPR mice. And here you can see that CAR-T cell treatment, or more precisely anti-CD19 CAR-T cell treatment, clearly prolongs the survival of these mice and, most importantly, also results in a drastic reduction and actually an abrogation of autoantibody production, showing that this approach might be also efficacious in human patients. And in Erlangen, we treated the first SLE patients with anti-CD19 CAR-T cells. In this case, the first patient was a young female suffering from a severe form of lupus, which affected almost all organs, and she remained refractory to other treatments. Transfer of CD19 CAR-T cells resulted in a rapid expansion of these CAR-T cells in the blood of the patients and a very efficient depletion of B cells. And even more importantly, when we looked at the clinical disease activity, here at the right, you can see the SLEDAI score, so a composite score, in the end, adding up disease activity of different disease domains. You can see that this SLEDAI score drastically decreased upon CAR-T cell treatment, and in the end, the patient reached a complete remission, basically losing all symptoms and all inflammatory disease activity. And also, when we looked at serological parameters such as production of autoantibodies, such as anti-double-stranded DNA autoantibody production, you can see that production of autoantibodies ceased. On the other hand, complement levels normalized. So complement consumption is usually seen when immune complexes consume complement, so a sign of disease activity. This normalized. And also proteinuria as a readout for kidney disease, for lupus nephritis, heavily decreased, and in the end, the patient also achieved complete remission in terms of the kidney involvement in SLE. So a drastic improvement of this patient. And one of the most striking findings was that we could stop all other treatments, including steroids and other immunosuppressants. And this patient is still in clinical remission without any other therapy for now more than 3 years. So here we really achieved a drug-free remission. I'm always careful of calling it a cure, but here we are at least close to a cure of an otherwise chronic autoimmune disease. Meanwhile, we treated several other patients. So here's data from a first cohort of 5 lupus patients. All of them responded very well. CAR-T cells expanded, and all of these patients benefited in terms of clinical disease activity, and almost all patients achieved complete clinical remission, here shown as a SLEDAI score. And also in terms of serological and clinical disease activity parameters, you can see the striking effect of this anti-CD19 CAR-T cell therapy with a drop in proteinuria, a normalization of complement levels, and a drop of autoantibody production, in this case, anti-double-stranded DNA antibodies. Questions, of course, what about side effects? Here we know that CAR-T cells are very effective. On the other hand, they also can cause severe side effects. A common side effect is so-called cytokine release syndrome, or shortly CRS, which is often observed in hemato-oncological patients receiving CAR-T cells. Fortunately, we observed just very mild CRS in patients with autoimmune disease, and so far no neurological complications, which are also observed in hemato-oncological patients after CAR-T cell therapy. So overall, a very good safety profile. The reason for this good safety profile is not completely clear, but we think that especially the rather low number of B cells circulating in these patients in comparison to hemato-oncological patients, which of course during B-cell leukemia, for instance, have much higher B-cell loads, results in a decreased rate of side effects. When we look now on the long-term follow-up of these first 5 patients, you see that they did not only reach low disease activity and clinical remission, but also could maintain this remission over a prolonged period without receiving any additional therapy. Interestingly, when we now look at different types of autoantibodies, we see that double-stranded DNA antibodies rapidly drop and disappear. However, we still see some other autoantibodies remaining to a certain extent. The reason for that is not so clear, but we think that in this case, the depletion of CD19 positive B cells, as well as short-lived plasma cells, which directly derive from these B cells, are the reason for the drop in double-stranded DNA antibodies, whereas other autoantibodies, such as anti-Rho antibodies, partially derive from long-lived plasma cells that are not touched by this CD19 CAR-T cell approach. When we now look in single-cell sequencing on a more molecular level, we see that in peripheral blood cells, here monocytes and T cells, especially the interferon signature is decreased upon CAR-T cell treatment. In this case, we compare gene expression profiles before and after CAR-T cell therapy. And here, the interferon signaling pathway is the most drastically and most significantly affected pathway. Here we know that type 1 interferon signaling is highly upregulated in lupus patients, and this typical signature is basically eradicated upon CAR-T cell treatment, which is also seen here as one example, ISG15 expression as one interferon responsive gene in peripheral blood cells that is heavily decreased. What about the long-term fate? So I've shown you that patients maintain clinical remission over a prolonged period of time. Interestingly, most of the patients show a disappearance of CAR-T cells in the peripheral blood. In some cases, we see remaining numbers, low numbers of CAR-T cells. However, they are most likely reaching an exhausted state, so they are no longer functional. Why do we think that? The reason is shown here. So in all of the patients, we saw a repopulation of B cells in the peripheral blood upon CAR-T cell therapy about 100 days after CAR-T cell therapy. So after an initial depletion of B cells repopulate in these patients. Initially, of course, that was a point that was of concern, as of course a repopulation of B cells might indicate also a reappearance of disease activity, which was obviously not the case. The question is why? And here we observed that the B cells that repopulated showed a naive phenotype, indicating that they differentiated from B cell precursors. So they basically expressed just IgD and IgM, no IgG or no IgA, indicating that they had not undergone a class switch. So they were really naive B cells. It's also shown here when we had a closer look by single cell sequencing. It became obvious that most of these B cells really had a naive phenotype or were transitional B cells that repopulated. All class-switched B cells were basically gone. When we now looked at the B cell receptors, it was clear that the so-called generation probability of the B cell receptors heavily increased upon CAR-T cell treatment within these repopulating B cells. And that's also indicative of a naive repertoire that is antigen inexperienced and did not undergo affinity maturation. Another interesting observation was that most vaccination titers remained rather stable. So you can see here, for instance, anti-tetanus antibodies, they are hardly affected by CAR-T cell treatment. The reason for that, again, might be due to the fact that we do not deplete long-lived plasma cells, which very likely contribute to the vaccination titer production, or to the antibodies in that case. And importantly, the patients that showed a repopulation of B cells nicely responded to new vaccinations. So in this case, we, for instance, immunized against SARS-CoV-2, and those B cells were plastic and responded again with a response to SARS-CoV-2 vaccination and with new antibodies. So the immune system after repopulation of B cells is fully functional. What about other autoimmune diseases? Meanwhile, we did not only treat systemic lupus, but also different other autoimmune diseases. One example is are patients with anti-synthetase syndrome, for instance, JO1 dermatomyositis. So in this case, the initial patients we treated also showed a refractory disease state, so they did not respond to multiple therapies. CAR-T cell treatment induced a very drastic remission in that case. On the left side, you see here the creatine kinase levels as a measure of disease activity, of myositis, of muscle inflammation. And here you see that these patients, for instance, did hardly respond to previous treatments, but as soon as he received CAR-T cells, the creatine kinase levels dropped into a normal range and remained there. Again, we saw a repopulation of B cells, but no reoccurrence of disease activity. And also when we looked in different affected organs, such as the muscle, we see nicely that muscle inflammation here visualized in MRI is completely gone after CAR T-cell treatment when we look after 3 months. The same is true for lung involvement in these patients. Here, patients usually develop a lung fibrosis upon lung inflammation. And here we see that this affection of the lung is also heavily decreasing and in the end disappears upon anti-CD19 CAR-T cell treatment. Quite impressive are also the patient-reported outcomes upon CAR-T cell treatment. So in this dermatomyositis patient who was heavily impaired in terms of his functional capabilities. So basically, he could hardly walk. About his walking distance was about 10 meters prior to CAR T cell therapy, and 3 months after CAR T cell therapy, he could already walk 1 kilometer. Whereas half a year after CAR T cell therapy, he was fully mobilized and could walk more than 5 kilometers. So here, a drastic improvement in terms of patient-reported outcomes in these severely sick patients. So overall, we think that CAR T cells are, on the one hand, a very efficient tool to deplete B cells. They have a rather good safety profile in this type of patients. And most importantly, they do not only induce clinical remission, but in most of the patients, we observed a drug-free remission, which so far is quite persistent and sustainable. So it will be, of course, important to follow up these patients, but we are optimistic, and this approach might, for some of these patients, be really an option to cure these otherwise chronic diseases. Would like to thank people involved. Here I have to mention that most of the work, as I already introduced, has been done in Erlangen. Here, Georg Schett, the head of the Department of Rheumatology and Clinical Immunology in Erlangen, was a key driver of this project, together with Andreas Mackensen, head of the hemato-oncological unit, and Dimitri Mugiakakos, who was a senior physician together with me, and we together we treated these patients. Thank you for your attention, and I'm happy to address questions.